Good afternoon. Welcome to Oncology Session 11, hepatobiliary and gastric carcinoma. So I'm pleased to say that we've left the best to last. So that's excellent. Well, it's my great privilege to introduce Professor Yuji Nakamoto to start off. He is Associate Professor of, in Nuclear Medicine and Radiology at the Kyoto University, Japan. And of course, Kyoto are going to be the site for our next World Congress. So it's great that we have that connection to the next World Congress. So over to you to talk about clinical utility of PET-CT in gastric cancer.
Thank you for your kind introduction. Hi, good afternoon, everyone. My name is Yuji Nakamoto in Kyoto University. It's a very honor for me to be here. Today, I'd like to talk about clinical utility of FDG PET-CT in gastric cancer. Learning objectives are demonstrated here. First, to review the characteristics of gastric cancer, and second, to learn clinical utility and limitations of FDG PET-CT in diagnostic imaging. For learning objectives in my talk, first I'd like to talk about epidemiology and current therapeutic topics. And then I'd like to discuss about PET-CT in gastric cancer. And finally, I'd like to share with you some interesting cases. Almost 1 million new cases of gastric cancer were estimated to have occurred in 2012, making it the fifth most common malignancy in the world, after cancers of the lung, breast, colorectal, and prostate. It is the third leading cause of cancer death mortality, with about 700,000 deaths worldwide. It has a significantly higher fatality to case ratio, about 70, than prostate cancer, 30%, and breast cancer, 33%. There are gender difference. Men are twice as likely as women, 14 versus about 7 per 100,000 people. And in addition, there are regional differences. Rates are highest in Eastern Asia, followed by Eastern Europe and South America. About 70% of the cases are diagnosed in Asia, and almost half of the cases are diagnosed in China alone. I'm from Japan, and gastric cancer is one of the most popular cancers that we have in clinical. Currently, the #1 cause of cancer death is lung cancer, but gastric cancer has been the first cause for cancer death in our country for many years. The most frequently used classification is a Lorentz classification, which was demonstrated in 1965. The Lorentz classification defines two main histological subtypes, intestinal type and diffuse type. The intestinal subtype is the most frequently diagnosed histology in high-risk populations and is more likely to be sporadic than inherited. It is diagnosed in mainly older patients and males more than females, and tumors tend to have gross appearance of ulcerated masses. The diffuse subtype of gastric cancer appears to be more aggressive than the intestinal type. It is generally diagnosed in younger patients and no gender difference. It can be associated with H. pylori infection, but it is more frequently associated with a loss of expression of E. cadherin. Within this subtype, signet ring cell carcinoma is occasionally observed. What are risk factors? There are some risk factors in gastric cancer as follows: H. pylori infection, salt, smoking, and alcohol. H. pylori infection is widely regarded as the most important and modifiable risk factor of gastric cancer. More than 2 billion people are infected worldwide, but fewer than 0.5% will develop gastric cancer. According to meta-analysis, H. pylori infection carried relative risk of gastric cancer about 3. Let's think of treatment of gastric cancer. Current US and UK guidelines recommend that all medically fit patients with regionally confined disease undergo primary surgical resection for up to stage 1 tumors and surgery after neoadjuvant chemotherapy for stage 2 to 3 tumors. Are there really benefits of neoadjuvant treatment or adjuvant treatment? To investigate the clinical significance of neoadjuvant chemotherapy, this randomized control trial was performed. In this trial, 503 patients were randomized to a surgery alone group and or a surgery after neoadjuvant chemotherapy group. In neoadjuvant chemotherapy group, another 3 cycles of chemotherapy was added when possible. As a result, a neoadjuvant chemotherapy group had better prognosis with a 5-year survival of 36%. As for the adjuvant chemotherapy, its usefulness has been verified based on meta-analysis. According to this meta-analysis, adjuvant chemotherapy is beneficial, although the size of the effect is small and the optimal agents are unclear. Adjuvant chemotherapy was associated with a significant benefit on overall survival and diffuse-free survival with a hazard ratio of 0.82. And the 5-year survival was improved about 50% to 55%. If patients have distant metastasis, such as liver mets or peritoneal implants, it is considered inoperable. This study compared between salvage chemotherapy plus best supportive care group and best supportive care only group. This median overall survival was 5.3 months in the salvage chemotherapy group, and it was 3.8 months in best supportive care group. According to this large phase 3 trial, their conclusion is that salvage chemotherapy is tolerated and significantly improves overall survival when added to best supportive care. Trastuzumab in combination with chemotherapy can be considered as a new standard option for patients with HER2 positive advanced gastric cancer. In this study, the difference of median survival time may be small, just for 2 to 3 months, but Herceptin group showed better prognosis with a median survival time of 13.8 months. In gastric cancer, one of the molecular targeted drugs, such as ramucirumab, has been approved and widely used. This drug is a monoclonal antibody, VEGFR2 antagonist. This rainbow study compared between ramucirumab plus paclitaxel group and paclitaxel only group. As a result, the combination of ramucirumab with paclitaxel significantly increases overall survival compared with paclitaxel only, and it could be regarded as a new standard second-line treatment for patients with advanced gastric cancer. I'd like to show you one more drug, immune checkpoint inhibitors, such as nivolumab. Nivolumab has been widely used in various cancers, such as lung cancer, melanoma, and so on. In patients with gastric cancer, it is suggested that nivolumab's prolonged median survival time, and in addition, 12 months overall survival was 26.2% in nivolumab group, while it was 10.9% in placebo group. Let's move on to the next topic, PET-CT in gastric cancer. First, let's take a look at detection rate, detection performance of FDG PET-CT for primary gastric cancer. This is an interesting study conducted in Japan about 10 years ago. For cancer screening purpose, volunteers underwent various examinations, including endoscopy, CT, and FDG PET. This table shows the number of PET-positive cases and negative cases for each malignancy. There are a total of 24 gastric cancer cases, which is confirmed by histopathologically, but just 2 cases were positive in PET, while the remaining 22 cases were negative in FDG PET. So therefore, we can say the detection rate of FDG PET for primary tumor is limited. Tumor detection by FDG PET depends on tumor size and histology. Early-staged tumors tend to be missed because of their small size, especially in diffuse type. In advanced gastric cancer, tumors are depicted in 90% of the intestinal type, while the detection rate was lower in diffuse type in this population. There have been several methods to improve the detection rate of FDG PET for primary tumors. As you know, we can see a physiological uptake corresponding to the gastric wall in stomach. So this may interfere the detection of primary tumors. So distension of gastric wall may be effective. This is a 70-year-old man who had a usual PET-CT scan, which is demonstrated in the upper row, and another PET-CT scan just after intake of water, indicated in the lower row. When we look at the upper row, the conventional PET-CT, we can say it's normal, maybe a physiological uptake in the gastric wall, but in the lower PET images, we may suspect it's maybe abnormal for gastric cancer. This table summarizes the comparison of detection rate of gastric cancer between before and after distension by taking water. In the third study, the detection rate was a little bit improved from 50% to 75%. But when we look at other studies, the sensitivity was comparable between the two, between before and after taking water. So this method, it seems that it's not be widely accepted. How about using FLT, fluorescence imaging, instead of FDG? In this report, first report, the sensitivity of FLT PET was 100%. It's higher than FDG PET, about 70%. But when we look at the other studies, the sensitivity seems comparable between the two traces. So I think frequency of diffuse type or small tumors may have affected that sensitivity. So it is difficult to detect gastric cancer with FDG PET. How about N staging? They demonstrate the diagnostic performance of FDG PET for nodal staging, comparing with that of CT and MR. According to this review article, the detection rate of FDG PET for nodal staging was low, with a sensitivity of 34% to 55%. Unfortunately, it is not satisfactory. How about detecting distant metastasis? There are some articles demonstrating promising results, but it seems controversial. For example, the diagnostic performance of CT and FDG PET was comparable, detecting liver mets and for peritoneal metastasis. both modalities showed substantially low sensitivity, about 70% for liver mets and about 30% for peritoneal implants. This may be partly because tiny lesions are missed by imaging modalities. In contrast, specificity was not so bad, more than 90%. So in summary, for preoperative staging, FDG PET has limited value in clinical. So it has been demonstrated that FDG PET was useful for detecting recurrent disease in various cancers, such as colorectal cancer. About 10 years ago, health insurance was not approved in gastric cancer in our country because of limited evidence. Therefore, we conducted multi-center study for evaluating FDG PET or PET-CT for recurrent gastric cancer. In this study, we divided patients into three groups according to their clinical situations. So group A means recurrence had been suspected by other imaging modalities, but FDG PET-CT scan was performed for restaging. And in group B, recurrence was suspected by rising tumor markers, but imaging modalities were negative. And group C, FDG PET was performed just for follow-up without clinical symptoms or evidence. When look at clinical impact, in group A and group B, therapeutic management was changed by FDG PET findings about half of the cases. In contrast, in group C, the clinical impact was low. Therefore, FDG PET or PET-CT should be considered in clinically suspected cases of recurrence after surgery. Here is another report mentioning diagnostic performance of FDG PET-CT in the evaluation of gastric cancer recurrence. In this study, sensitivity, specificity, accuracy are 91%, 62%, and 82% respectively. As compared with our study, which was demonstrated in the previous slides, the specificity seems to be low. And for detecting primary tumors, histology affected the diagnostic performance. How about recurrent cases? In detecting recurrent or metastatic sites, detection rate depends on histology, as is shown in this table. And lower diagnostic performance is observed in signet ring cell carcinoma or mucinous carcinoma. And I would like to show you one more interesting article from Korea regarding the clinical significance of FDG PET in addition to enhanced CT. If CT findings and PET findings are same, there's no problem. But what if it's discrepant? Let's think about a third case. So in this case, CT positive and PET-CT negative. And there are 11 cases. And 6 of 11 cases, a PET scan was, clinical decision was made by PET-CT findings. But actually, 4 cases were positive. So it's 4 cases are positive, actually positive. So there are 4 false negative cases in FDG PET. And in the last group, CT negative and PET-CT positive, there's one case which was a clinical decision was made based on PET-CT findings, and it was true positive. So there were 13 cases, and in which 2 modalities were discrepant, inconsistent. And these 7 cases were judged based on PET-CT findings, meaning they trusted PET findings. But accuracy was obtained in 3 of 7 cases, less than 50%. So their conclusion is additional PET-CT on contrast CT did not increase diagnostic accuracy. So let's think about predicting or monitoring therapy response by FDG PET. This chart shows time course of SUV max in responder group and non-responder group. Responders and non-responders were determined by RECIST criteria after neoadjuvant chemotherapy. Circles indicate responders, and triangles indicate non-responders. There is a difference between the two groups at early week of 6. Therefore, it is suggested that PET-CT findings could predict a response for neoadjuvant chemotherapy accurately in earlier stage. In this article, the authors prospectively evaluated the predictive value of FDG PET in neoadjuvant chemotherapy. They stratified patients based on metabolic response. When reduction of FDG uptake was greater than 35%, they were regarded as responders. The left chart shows the overall survival from start of chemotherapy, and right chart shows the overall survival after curative tumor resection. Both charts shows the metabolic responders showed better prognosis. In this recent study, published this year, they retrospectively reviewed 124 patients with locally advanced gastric cancer who had undergone baseline PET-CT before chemotherapy, including trastuzumab. SUV max of primary tumors had no prognostic value, which is demonstrated in the left side, but the volumetric parameter, such as whole body total lesion glycolysis, is stratify the overall survival. Their conclusion is in both HER2 negative patients and HER2 positive patients receiving trastuzumab, volumetric parameters in FDG PET-CT may have a role in predicting prognosis in stage 4 gastric cancer. How about a prediction of response to ramucirumab or nivolumab by FDG PET? This is one of the important issues in clinical because drugs are expensive and stratification is significant from a point of view of cost effectiveness. And also, we need to avoid side effects. When I put ramucirumab or nivolumab, cancer, and FDG in the box in PubMed, there were 11 related articles. However, when limited to gastric cancer, no relevant articles were detected. And when we put PET instead of FDG, there were 31 articles. But when limited to gastric cancer, one review article was identified. So far, there have been no articles demonstrating a predictive value of PET-CT in earlier stage for these drugs. Hopefully, there may be an article addressing this issue in the near future, as has been demonstrated in lung cancer. In lung cancer case, they used kappa-64 labeled ramucirumab. But finally, I'd like to introduce some interesting cases. This is a 69-year-old male with hypopharyngeal cancer, not gastric cancer. PET-CT was performed for staging. We can see a large intense hypermetabolic area corresponding to a primary tumor or hypopharyngeal cancer. How about this uptake? Actually, this uptake is located in the posterior wall in antrum, and we suspected a possibility of gastric cancer, and endoscopy was performed. Endoscopy revealed ulceration here, but it's in the anterior portion of gastric lesser curvature. The final diagnosis was signet ring cell carcinoma. The location is different between where we suspected and where we got pathology. So therefore, this case is considered false positive and false negative. It is difficult to detect gastric cancer. This is a 70-year-old male with gastric cancer who had PET-CT scan for staging. Maybe this we can see uptake in stomach, indicating primary gastric cancer. But the blood sugar level was not so high, 125, but it was turned out that the patient had a meal just 3 hours ago. So a week later, another PET-CT scan was performed. We can see a hypermetabolic area in the liver, unexpectedly indicating liver metastasis. Liver metastasis was also confirmed by MR, and scheduled operation was canceled. As you know, fasting is very important, but we do not care about blood sugar level in clinical. I'd like to show you this case. This is a 74-year-old female, and gastric cancer was diagnosed in another hospital. Endoscopy showed ulcerative mass, and pathology of poorly differentiated adenocarcinoma was obtained. Then PET-CT was performed. We can see many abnormal uptakes. Do you think stage 4 disease of gastric cancer? Actually, we suspected lymphoma because it is unusual distribution in gastric cancer. The referring physician told the pathologist our interpretation and asked possibility of lymphoma. And pathology in primary site was re-evaluated. Immunohistochemical staining confirmed that diffuse large B-cell lymphoma. In this case, PET-CT findings changed the pathological findings, which was considered very helpful for proper treatment in this patient. I said distribution pattern is important, but both parents had been suspected of having lymphoma. But this left one distribution is characteristics of sarcoidosis, which was confirmed by biopsy. In the right, we can see intense uptake in submandibular gland, mediastinum, and bilateral hilum, spleen, and retroperitoneum, and just below the bladder, maybe indicating prostatitis. And also he had nephritis bilaterally. What do you think of this case? Yeah, of course, it's IgG4-related disease. If we search using this word, such as steatohepatitis, nodal swelling, retroperitoneal fibrosis, prostatitis, Google tells us IgG4-related disease, a kind of artificial intelligence. Last case, PET-CT scan was performed for staging of gastric cancer. What do you think of this distribution? Exercise? I guess everyone does not consider this uptake is abnormal for metastasis, but why hypermetabolism can be seen like this? Actually, he has no exercise for half a day before PET scan because he had been asked not to do exercise, but he had sexual activity at previous night. So we should keep in mind that hypermetabolism of skeletal muscles following sexual activity can last over 12 hours. So in summary, FDG PET-CT is not always, but occasionally useful in gastric cancer. I guess it is not necessary to have roadmap when you are driving a car to your workplace, But imagine you are driving a car in the countryside during a night, like this picture. And imagine you are a stranger there, and imagine it's snowing. It's not snowing in this picture. Are you okay just if you have a road map? If you have a navigator, I believe you have more confidence, and it may save your life. PET-CT with FDG is not always necessary in gastric cancer, but I'm sure sometimes useful. Thank you for your attention.
Thank you very much, Professor Nakamoto, and we'd just like to present you with the token. Thank you.
One more?
Thank you. Thank you very much. We now move to a different part of the body, close by, with liver. And we're very pleased to have with us Dr. Seung-Young Kwon from Chonnam National University at Kwasan Hospital, Jeonnam in Korea. And he's going to talk about PET imaging in HCC, particularly looking at C11 acetate and FDG PET-CT in hepatocellular carcinoma research. Thank you very much.
Thank you, Chairman, and ladies and gentlemen. I'll talk about acetate and FDG PET for hepatocellular carcinoma research in South Korea. Firstly, I will review overview about hepatocellular carcinoma, and I will introduce the FDG PET for HCC research in South Korea. And then I will show the several cases and preliminary research in our institution, and I will summarize them. As you know, the primary liver cancer is the second leading cause of cancer-related deaths worldwide, and HCC represents about 90% of all cases of primary liver cancer. Compared to other cancer staging systems, HCC has different scoring or staging system. Unfortunately, the molecular classification of HCC has not been established yet, so it makes it difficult to find the druggable target. Especially, so primary liver cancer has a broader spectrum according to the cellular differentiation from the classic type of HCC to cholangiocarcinoma. It also makes it difficult to find the druggable target. So there are several staging and scoring systems have been developed. The Barcelona Clinical Liver Cancer Staging Classification, BCLC, is the main clinical algorithm for the stratification of patients according to prognosis and treatment allocation. And its staging system very useful to select for the best candidate for the best therapies. And this system consists of 5 categories according to the several risk factors. And child poor classification and MELD scoring system is another other scoring system for assessing the liver function or severity of liver disease. In BCLC staging system, the patient with very early to injury stage 0 or A are usually candidate for the radical therapy, ablation, rejection, transplantation, ablation, transplantation. And in the patient with indeterminate stage, stage B, is required for the transarterial chemoembolization, and in the patient with advanced stage, stage 3, are potentially candidate for the targeted therapy, especially sorafenib. Child poor classification assessed the severity of liver disease according to the ascites, bilirubin, albumin, prothrombin time, and encephalopathy. And these classes correlate with 1 and 2-year patient survival. And the other scoring system is the MELD scoring system. This scoring system is used to assess the severity of chronic liver disease, and MELD scoring system use this equation consisting of the bilirubin, creatinine, and INR. And 3 months observed mortality is different according to the each MELD scoring category. So there are many studies to evaluate the clinical role of PET-CT in HCC, but several issues are ongoing, especially imaging or metabolic parameters as better tool, and the precise performance for recurrence or metastasis, and patient selection for therapy and monitoring during the therapy or the management. So I will introduce the several studies in the South Korea. So as you know, the medical examination, including PET, CT, should satisfy the requirement from each stakeholder, especially, for example, the appropriate outcome in the patient aspect and appropriate use or management in hospital aspect, and the social benefit, the reimbursement issue in the regulatory or public funding institution. So we needed to develop the reasonable indication for preoperative FDG PET in HCC. The clinical trial network, CTN, for HCC in South Korea was supported by the Korean SNM, and the multi-center retrospective cohort study was performed to correlate between the metabolic parameters on FDG PET and prognosis in these patients. So from those studies, they used the tumor to normal liver uptake ratio was used the parameters on PET-CT, and they evaluate the PET-CT parameters, clinical role of PET-CT parameters with prognosis in each BCLC stage. The first published study evaluated the prognostic significance of FDG uptake in HCC treated with TACE or CCRT. And this study includes a patient with a BCLC stage B or 3, and those patients underwent a TAC or CCRT as initial treatment. So before introduce the result, the cutoff value determined by ROC analysis for TLR, tumor to normal liver uptake ratio, was 2.0. So this survival curve shows the TLR. The higher TLR in the worse prognosis for the progression-free survival and overall survival. Interestingly, subgroup analysis, from the subgroup analysis, the patient with higher TLR, more than 2.0, so this patient had the patient with a CCRT had a survival benefit compared to the patient with a TAC. But the subgroup with a low TLR, less than 2.0, there was no significant of outcome between the according to the therapeutic management. So TLR was a significant independent prognostic factor for both PFS and OS. And in patients with TLR greater than 2.0, the patient treated with CCRT showed significantly lower disease progression and mortality risk than those treated with TACE. The other study evaluated the prognostic value of FTG PET in the patient with a BCLC stage 0 and A. This study also used TLR as the main PET-CT parameters, and this study classified the patient into two cohorts, the curative cohort and the non-curative cohort. So the patient who underwent TAC had a significantly shorter survival than those who underwent curative treatment. Okay. In subgroup analysis, in curative cohort, the TLR was a significant prognostic factor for overall survival. On the other hand, in TAC cohort group, there was no significant of prognosis difference according to the TLR, but the Melder scoring system was a significant prognostic factor for overall survival. So, multivariate regression analysis shows that the TLR in curative cohort and Melder scoring score in TAC cohort were the significant prognostic factor for overall survival, respectively. And TLR was only prognostic factor for recurrence-free survival in the curative cohort. So pre-treatment TLR measured using PET is independent prognostic factor for survival in patient with BCLC stage 0 or A undergoing curative treatment. On the other hand, Melder score appeared to be important to predict the prognosis of patient undergoing TAC. Another study evaluated the PET-CT role to predict the survival in the patient with advanced stage, BCLC stage 3. So this study classified the patient into two subgroups, intrahepatic and extrahepatic. Extrahepatic include the patient with a lymph node or distant site involvement. So this survival curve shows that there was significant differences in overall survival only according to the extent of disease. The patient with extrahepatic disease show the worst prognosis for worse overall survival. In intrahepatic subgroup, the child 4 and TLR were the independent prognostic factor for overall survival. In extrahepatic subgroup, the only TLR was the only independent prognostic factor for overall survival. These two patients had a bone metastasis, and one patient had a low FTG uptake, TLR 1.5, in the left lobe. So this patient survived for the 20 months. On the other hand, the second patient had a high uptake TLR, 4.3 in the right lobe. So unfortunately, this patient died after 2 months. From this study, the intrahepatic subgroup, child 4 and TLR, were independent prognostic factor for OS. In extrahepatic disease group, TLR was the only independent prognostic factor for overall survival. This study evaluates the clinical role of FTG PET-CT to predict the microvascular invasion in HCC patients. As you know, microvascular invasion defined as the tumor cells in the portal or hepatic venules and capillaries. And it has a role as the prognostic indicator related to tumor recurrence. But it is hard to detect with preoperative conventional imaging studies. So this this study including the patient with HCC, BCLC stage 0 or A, and PET-CT was performed before the curative surgery. And logistic regression analysis was performed to identify the significant parameters associated with NVI. This survival curve shows the patient with NVI had a worse prognosis compared to patient without NVI. This analysis shows that the alpha-fetoprotein, TLR, and the tumor size were independent independent factor to predict the MVI. And the TLR of 1.3 on FDG-PET-CT was found to be optimal cutoff value to predict the presence of MVI. So this ROC curve was generated using the three significant factors combination. So this graph shows the favorable diagnostic performance with an AUC of 0.756. Microvascular invasion is a significant predictor for recurrence and survival after curative therapy. And TLR of 1.3 was optimal cutoff for MVI prediction. And the combined model with the TLR size alpha-fetoprotein level is might be have promising tools to predict the MVI. So interim summary. In patient with BCLC stages B or 3, the TLR was independent prognostic factor for both PFS and OS. And the patient with high TLR have a benefit from CCRT compared to the patient with TACE. Second study, in the patient with stage 0 or A, TLR was also independent prognostic factor for OS in curative cohort. On the other hand, the MELD score is significant factor for overall survival in TACE cohort. The third study, including the patient with stage 3, the TLR was higher in extrahepatic environment and high TLR 3.0 in intrahepatic and 3.2 in extrahepatic, different cutoff value have also independent factor for worse overall survival. Last study, including the patient with stage 0 or A, the high TLR 1.3 was a significant factor to predict the MVI, and the combination of these TLR alpha-fetoprotein size might be the potential to the better tool to predict the MVI. Okay, I will introduce another study in our country about the patient selection for targeted therapy. This study evaluates the clinical role of FDG-PET in the patient with sorafenib treatment. So this study includes a patient with BCLC stage 3 treated with sorafenib for at least 30 days. And PET-CT was performed within 1 month before sorafenib treatment. And 51 patients were excluded because those patients underwent a local therapy like TAC, RFA, RT surgery during the sorafenib treatment. So before introducing the result, the cutoff value of TLR was determined by with a median value of TLR of total enrolled patient. So the table and the graph shows that the patient with higher TLR shows shorter overall survival and shorter progression-free survival compared to patient with a lower TLR group. This analysis shows the child born and TLR were independent factor for overall survival. And TLR was the only prognostic factor for progression-free survival. So from this study, treatment tumor metabolic activity, TLR, is independent prognostic factor for survival in patients with BCLC stage 3 receiving sorafenib monotherapy. And the higher treatment showed rapid disease progression after sorafenib and can be considered as potential candidate for concomitant local therapies. So I will introduce the previous study about acetate pad and the preliminary study in our institution. So from the previous study, the addition of acetate pad to FTG pad increased the overall sensitivity for the detection of a primary region, but there was no significant difference between two tracers in sensitivity for metastatic tumor size, location, differentiation. Another study shows FTG pad alone has a reasonable sensitivity in the detection of HCC metastasis, although dual tracer protocol has a mature complementary advantage in some extent. So I would like to evaluate the diagnostic impact of acetate pad over FTG pad according to metastatic site in the patient with HCC. I used the dual tracer protocol for the diagnosis of HCC patient, and true positivity was defined as the discernible focal uptake and detectable but the smaller region. And I classified the enrolled patient into two subgroups. Group 1, the subgroup according to the involved site, and group 1 metastatic bone lesions and group 2 metastatic regions other than bone. Enrolled 40 patients, 18 patients had extrahepatic metastasis. So from the table, the metastatic bone lesion was most frequent site compared to other site. Okay, when we compare the detection sensitivity of each tracer according to the metastatic site, in the bone metastasis, acetate pad had a very good sensitivity compared to FTG pad. And in the other site metastasis subgroup, there's no significant difference of diagnostic accuracy between two modalities, but dual trace analysis make it significant improvement to detect the metastasis. Before I compare the metabolic activity of each tracer, there's no significant of size between two groups. Okay, in group 1, bone metastasis, the max SUV of acetate is significantly higher than FTG, but interestingly, the max SUV of acetate max SUV in bone is also higher than in acetate uptake in other site. So this case had a metastatic bone lesion in T8 vertebra. So acetate PET shows focal uptake in this site, but there was no uptake in FDG PET. Other patient had a small bowel metastasis. So FDG PET showed focal FDG uptake in the small bowel, but there was no acetate uptake in the same site, except for the physiologic or inflammatory uptake in the liver. So from this preliminary study, bone metastases are not rare in HCC, and acetate PET was very useful for the detection of small-size bone metastasis. And acetate PET CT role was enhanced with FTG for the detection of other site metastases. Okay, to approach or understanding this phenomenon, I should focus on the tumor microenvironment as well as the lipid metabolism. So as you know, the stromal cells have an important component of tumor microenvironment, and adipocyte, among them, adipocyte induce the homing of metastatic cancer cells and release the fatty acid. And fatty acid and lipid have a central role in the communication between cancer and stromal cells. So cancer cell metastasis to the bone marrow, including the many adipocytes, they can overexpress the fatty acid binding protein and modulate the metabolic pathway toward the acetate amide process for the energy production. So bone marrow, as you know, had many adipocytes compared to other organs, and which environment can affect the different diagnostic performance of C11 acetate PET according to the metastatic site. Although we need to further research. Lastly, I will show the one case about issues about side effect monitoring. This patient had HCC and underwent sorafenib for 10 months, and he admitted to the hospital, and medical examination demonstrated that the normal anion gap before after admission, the acetate PET was performed, and hot liver uptake was shown. 1 month after the withdrawal of sorafenib, the liver uptake significantly decreased to within normal range. So from the references, the under metabolic acidosis buffering system serves to normalize the pH, and buffering system, including the acetate, act as an endogenous source of bicarbonate and require the hepatic metabolism. So the processing of these compounds require the alteration of liver metabolism via acetate accumulation. Also, we need to the further evaluation also. Okay, in summary, ladies and gentlemen, in each BCL stage, FTG uptake in primary tumor has a very prognostic tool in PFS and both PFS or OS, and acetate PET was complementary role according to the metastatic site, although we need to the further evaluation. So multi-center study can be helpful to the reinforcement of evidence, but we need the further study or multidisciplinary research with other department or other physicians for the precise validation of opacity indication for the better outcomes and the therapeutic guidance. Thank you for your attention.
We have a small token of our thanks. Thank you very much.